If you find yourself taking a small pill each morning to manage your blood pressure, yet still feeling constantly drained, noticing weight gain around your waist, or struggling to climb stairs without getting out of breath, there's a strong possibility your doctor has prescribed you a beta blocker. What's concerning is that the latest scientific research reveals something many physicians have yet to fully acknowledge: that medication might actually be doing more harm than good. I'm Dr. Luis Manochi, and this channel is dedicated to bringing you the most up-to-date, evidence-based insights on senior health, presented in a way that's clear and tailored for adults over 60. If you haven't subscribed yet, now is the time to hit that button, because what we're discussing today could reshape the conversation at your next doctor's visit. So, let's dive right in. Beta blockers. You might recognize them by their brand names like Metoprolol or Lopressor, or their generic forms, Metoprolol and Atenolol. These medications have been prescribed for high blood pressure for more than 50 years. Doctors write millions of prescriptions for them annually. They're affordable, widely known, and for a long time, they were considered the gold standard for treating hypertension. But here's the issue. The research has evolved. For many seniors with straightforward high blood pressure, beta blockers are no longer the optimal choice and may actually be worsening several aspects of your health simultaneously. Let me explain how beta blockers function in your body. Your heart has receptors. Think of them as locks on a door. Adrenaline acts as the key that fits into those locks, causing your heart to beat faster and with more force. Beta blockers occupy those locks, preventing adrenaline from binding. This slows your heart rate and reduces the intensity of each heartbeat, which in turn lowers your blood pressure. This mechanism sounds logical, and for specific conditions, such as recovering from a heart attack, managing heart failure, or treating dangerous heart rhythms, beta blockers are genuinely life-saving. Their value in those scenarios isn't in question. However, for routine high blood pressure in otherwise healthy seniors, the evidence has shifted dramatically. The turning point came with a groundbreaking study known as the Ascot Trial, or the Anglo-Scandinavian Cardiac Outcomes Trial, published in The Lancet. This study followed over 19,000 patients with high blood pressure, comparing those taking a beta blocker plus a diuretic against those on a calcium channel blocker plus an ACE inhibitor. The trial was halted early because the results were so clear. The group on beta blockers experienced significantly more strokes, heart attacks, and new diabetes diagnoses. Meanwhile, the calcium channel blocker group saw a 23% reduction in major cardiovascular events, a substantial difference. Following this and other supporting studies, the United Kingdom's National Institute for Health and Care Excellence officially removed beta blockers from their list of recommended first-line treatments for hypertension. They are no longer the preferred option in British guidelines. Yet, millions of Americans continue to take them as their primary blood pressure medication, often because their doctor prescribed them years ago, and no one has revisited that decision since. Let me know in the comments right now. Are you currently taking Metoprolol, Atenolol, or another beta blocker for your blood pressure? Just answer yes or no. I want to understand how many of you this affects. Now let's explore the specific ways these medications might be working against you, especially if you're over 60. The first issue is fatigue and exercise intolerance, and this matters more than most doctors realize. When beta blockers block the adrenaline receptors in your heart, they limit how high your heart rate can rise. For a younger person sitting at a desk, this ceiling might go unnoticed. But for a 65-year-old who wants to walk around the neighborhood, swim laps, or keep up with grandchildren, this limitation means hitting a wall much sooner. You feel out of breath faster, your legs feel heavier, and exercise feels harder than it should. Since physical activity is one of the most effective ways to naturally lower blood pressure, struggling with it creates a frustrating cycle. The medication makes exercise more difficult, and less exercise means your blood pressure remains elevated. Take Harold, for example. At 71, he came to me complaining of profound fatigue, so severe that he'd stopped his evening walks entirely. He'd been on Atenolol for 3 years. During that time, he gained 14 pounds, his blood sugar crept into the pre-diabetic range, and his energy levels, as he described it, felt like running on half a tank every single day. His previous doctor had chalked it up to aging, but when we reviewed his medication alongside the latest evidence, the picture became much clearer. The second concern is metabolic damage, and this is well documented. Beta blockers increase insulin resistance, raise triglycerides, and lower HDL, your good cholesterol. A comprehensive meta-analysis published in the Journal of the American College of Cardiology found that patients on beta blockers had a 22% higher risk of developing type 2 diabetes compared to those on other antihypertensives. For seniors already managing blood sugar or hovering in that pre-diabetic range, this is a significant risk to add with a medication that isn't even outperforming its alternatives. Here's what genuinely surprised me as I reviewed this data. Beta blockers often do lower your blood pressure numbers. The cuff reading may look acceptable. The problem lies in what's happening beneath the surface, the metabolic disruption, the cardiovascular outcomes, and the gradual erosion of your quality of life. You could have a reading of 128/78 and still be silently accumulating harm if your medication is undermining your metabolic health at the same time. The third issue is the risk of falls, which is critically underappreciated in older adults. Beta blockers can cause orthostatic hypotension, a sudden drop in blood pressure when you stand up from sitting or lying down. That brief dizzy spell when you rise from a chair? For a 73-year-old, it's not just uncomfortable, it's a fracture waiting to happen. Hip fractures in seniors over 70 carry a 1-year mortality rate approaching 30%. A medication-induced fall isn't just a fall. Before I share what the research supports as better alternatives, I need to make one thing absolutely clear, and this could save your life. Never stop taking a beta blocker on your own without medical supervision. Stopping abruptly can trigger a dangerous rebound effect, causing your heart rate and blood pressure to spike rapidly, and in some cases, leading to a heart attack or serious arrhythmia. Any transition away from these medications must be supervised by a physician and done gradually over several weeks. What I'm providing today is information and questions to discuss with your doctor, not permission to make changes to your medication on your own. So, what does the evidence actually support as better alternatives for seniors with uncomplicated hypertension? 2 medication classes stand out. The first is calcium channel blockers, with Amlodipine being the most commonly prescribed. The Ascot data strongly favored this class over beta blockers. It doesn't carry the same metabolic risks, it doesn't limit your exercise capacity in the same way, and a large analysis published in the British Medical Journal confirmed that Amlodipine was associated with significantly lower stroke risk than Atenolol in elderly hypertensive patients. The second strong alternative is AC inhibitors and their related class, ARBs, angiotensin receptor blockers. Medications like lisinopril, ramipril, Losartan, and olmesartan have shown consistent benefits in senior populations, offering protective effects for the kidneys, better outcomes for patients managing diabetes, and a lower risk of falls. ACE inhibitors do cause a persistent dry cough in about 10 to 15% of patients. If that's you, an ARB is generally the better choice, as it works through a similar mechanism without triggering the cough. Dorothy was 74 when her cardiologist reviewed her long-standing beta blocker prescription and gradually transitioned her over 8 weeks to Amlodipine combined with Losartan. Within 3 months, her fasting blood sugar had normalized. She'd lost 7 pounds without making any intentional dietary changes, and she described feeling like herself again for the first time in years. Her blood pressure readings were actually more consistent, not less. Here's exactly what you should do with this information. First, review your current medications and identify whether you're taking a beta blocker specifically for blood pressure, not for a diagnosed heart rhythm problem, not for post-heart attack management, and not for heart failure, but purely for hypertension. The names to look for include Metoprolol, Atenolol, Bisoprolol, Propranolol, and carvedilol. Second, write down 3 specific questions to ask at your next appointment. Was my beta blocker prescribed specifically for hypertension? And does that still align with current evidence-based guidelines? Have we checked my fasting insulin and triglyceride levels recently? Would I be a candidate for transitioning to a calcium channel blocker or an ARB based on my overall health? Third, request a formal medication review. If you've been on the same blood pressure medication for more than 2 to 3 years without reassessment, you're entitled to ask for one. Many seniors are taking medications that were standard in 2005 but have since been reconsidered based on new evidence. Fourth, if any transition is recommended, confirm the tapering schedule with your doctor. A responsible physician will reduce beta blockers gradually, typically over 4 to 8 weeks, and monitor you throughout the process. Fifth, start tracking your symptoms now. Keep a simple daily log of your morning blood pressure reading, your energy level on a scale of 1 to 10, and your fasting blood sugar if you're monitoring it. 3 to 4 weeks of your own data gives your physician something concrete to work with and makes the conversation far more productive. One important note before we wrap up. There are absolutely patients for whom beta blockers remain the correct and appropriate medication. If you have coronary artery disease, a history of heart attack, diagnosed heart failure, or certain arrhythmias, including atrial fibrillation, the calculation is different. The evidence supporting beta blockers in those conditions is solid and well established. The concerns we've discussed today apply specifically to seniors whose only diagnosis is hypertension, elevated blood pressure without an accompanying cardiac condition. If that's you, this conversation is absolutely worth having with your doctor. If your blood pressure medication is leaving you exhausted, your weight is creeping up, your blood sugar is trending in the wrong direction, and your prescription hasn't been reviewed in years, you now have the research, the language, and the specific questions to approach your next appointment differently. You deserve a treatment plan built on current evidence, not decades-old habits. Comment, "Reviewing mine," if you're planning to bring this up with your doctor. Share your current blood pressure medication below. I read every response, and your question might inspire a future video. If someone you care about is struggling with their blood pressure management, please share this with them today. One conversation, armed with the right information, can genuinely change outcomes. I'm Dr. Louis Manochi. If you haven't already, subscribe, because next week, we're covering the silent mineral deficiency that makes blood pressure medications significantly less effective, and most doctors never test for it. I'll see you there. Take good care of yourselves.